So the third lecture will be a clinical application of the dual PCA from Professor Sang-Sing Choi from South Korea. He's not here. Yes, okay. So our guest speaker is coming all the way from Korea University Medical Center. He's a pain specialist and professor. He's currently interested in research and development, and he's particularly interested in development of medical devices. Currently, there are 2 products on the market where his ideas have been realized. One is electrically stimulating epidural catheter for epidural neuroplasty and epidural anesthesia. And it's commercially available under the trade name of Epistem and Regional Stem. His work and research are there for many years, and to date, multi-chamber PCAs have been commercialized as 2 types of dual chamber PCA under the trade name of Belomic Duo and Belomic Evo. In addition, although it has not been commercialized, his interest in the drug delivery system is important, and research on this is evolving and is ongoing. Please, Professor Choi.
Thank you for your kind introduction. Hello, I'm Dr. Choi. I'm working at the Korea University Medical Center as a pain specialist. I'm happy to give a lecture on dual chamber PCA I have developed. Today's lecture is about the characteristics and clinical applications of this new dual chamber PCA. PCA devices have evolved enormously in technological sophistication, ease of use, flexibility, and portability. PCA devices can divide into microprocessor, sophisticated programmable electronic PCA pumps, and simple foreign mechanical pumps. Electronic PCA have many advantages. Above all, electrical PCA pump shows accurate drug delivery within the error range of 5%. It has great flexibility in drug administration through a variety of adjustable bolus dose, flow rate, and rubber time interval. It can provide various information such as drug injection history and the delivery to attempt ratio through large display. It can alert you to abnormal situation. This versatile feature makes it suitable for research use. However, electronic PCA also have many disadvantages. Among other things, the most significant disadvantages are lethal injection by programming errors and the risk of opioid misuse by some patients. Although there are some horrible electronic PCA is significantly less horrible than mechanical PCA. The maintenance cost of electronic PCA is high due to the cost of battery, disposable accessory set, and medical staff workload. The noise generated by electronic PCA is also a problem. Noise, especially in the middle of the night, it can disrupt the patient's sleep. Other disadvantages include inappropriate alarm, the high price of the device, and the risk of inadvertent disconnection. Mechanical PCA devices overcome many of the drawbacks of electronic PCA devices. Mechanical PCA maximizes portability by lightweight and small size. It increases safety. Because mechanical PCA do not operate by programming like electronic PCA, the risk of lethal injection by programming error can be avoided. It can also prevent opioid misuse by intentional reprogramming of some patients. Because it is disposable and easy to use, maintenance costs can be minimized by reducing the cost of battery, disposable accessory set, training time for patients and patient caregivers, and medical staff workload. Unlike the electronic PCA, no energy supply required for operation. The drug infusion rate can be controlled to some extent through a slightly adjustable flow rate, or dose, and Lavanta interval. For these reasons, portable mechanical PCA has become mainstream in clinical practice. However, portable mechanical PCA devices released so far also have significant limitations. For effective pain control, mechanism-based multi-drug therapy, synergistic combinations of several compounds with different drug mechanisms can increase therapeutic efficacy and reduce side effects. With the ongoing national opioid crisis, opioid sparing strategies permitting to reduce the use of perioperative opioids are now recommended. For this purpose, the use of non-opioid adjuvant such as NSAIDs or acetaminophen is useful. It reduces opioid requirement and side effects compared to opioid use only. To achieve the effect of mechanism-based multi-drug therapy in conventional one-chamber PCA, opioid and non-opioid adjuvant must be mixed at the same time. When several drugs are mixed at the same time, there is problems such as precipitation, ionic reactions, and evolution of gas occur due to drug interaction. Therefore, mixing different drugs in the same chamber is not recommended. The basic concept of PCA is to administer a specific opioid above the minimum effective analgesic concentration and to maintain blood concentration within the therapeutic range that does not cause the side effects of the drug. Additionally, in this figure, for post-operative pain control, opioids should be administered to maintain a therapeutic blood level for about 2 or 3 days after surgery. And it is assumed that the patient's post-operative pain is constant during the treatment period. However, the intensity of pain doesn't remain constant. As you know, the pain decreased over time, especially from the second day after surgery. For this reason, when traditional one-chamber PCA is used, there is a high possibility of insufficient pain relief on the first post-operative day, and drug side effects, especially nausea and vomiting, leading to discontinuation of PCA treatment from the second post-operative day. After, for proper post-operative pain control, a sufficient amount of analgesics should be administered on the first post-operative day, and reduced analgesics should be administered the second post-operative day. However, conventional one-chamber PCA cannot meet these needs. To overcome the limitations of conventional one-chamber PCA, I devised multi-chamber PCA. This slide shows a type of dual-chamber PCA, product name Pro, developed as the world's first multi-chamber PCA. Dual-chamber PCA consists of a continuous channel chamber and a select bolus channel chamber. The continuous channel infuses the drug at a fixed rate with an adjustable flow rate of 1 or 2 milliliters per hour for basal infusion. The select bolus channel can adjust the flow rate 0, 1, or 2 milliliters per hour and can administer a bolus of 1 milliliter with log time 10 minutes. Each chamber volume is 100 milliliter and the total volume is 200 milliliter. The advantage of dual chamber, firstly, dual chamber PCA can prevent mixing of two drugs. Currently, two types of dual chamber PCA have been developed, but PCA devices with more chambers are needed to prevent mixing more drugs. Dual chamber PCA has better flexibility than conventional one chamber PCA. The dosing rate over time can be adjusted to some extent by filling each chamber with a different volume of solution. For example, if there are 100 milliliters of drugs in the selector bolus channel, 50 milliliters of the same drug in the continuous channel, and if the basal drug infusion rate of two chambers is the same, and 100 milliliters of drug is injected over 2 days and allowed to use of bolus, then the amount of the drug infused on the first day is at least twice the dose on the second operative day. In this way, the dual chamber PCA can adjust the dosing rate to some extent over time. When post-operative pain is controlled using these characteristics of dual chamber PCA, more properly pain relief and reduced drug side effects can be obtained. If one chamber is filled with opioid and the other chamber is filled with non-opioid adjuvants and antiemetics, dual chamber PCA can still be used despite the opioid side effects by locking the chamber containing opioid and allowing this chamber the drug administration from this chamber. For example, assume that there are 100 milliliter solution of fentanyl in the continuous chamber and 100 milliliter solution of ketorolac and densifluor in the selector with bolus chamber. And assume that severe opioid-induced nausea and vomiting occur, then fentanyl infusion has to be stopped. In such case, fortunately, because of the use of dual chamber PCA, although patient does not obtain analgesic effect of opioid from the continuous channel chamber, the patient can still get the analgesic effect of ketorolac and the antiemetic effect undensity from the other chamber. Another useful advantage is one of the two chambers can be reserved for further drug administration. When defect of the used drug are insufficient, then additional drug can be administered to the empty chamber. And in the event of drug side effect, therapeutic drug can be administered to the empty chamber. This slide shows the other type of dual chamber PCA, product name Bellomic Evo. It has been recently developed. The 200 milliliter chamber is used for large volume of pre-filled non-opioid drug, such as 100 milliliter acetaminophen IV solution or acetaminophen ibuprofen combination IV solution. Maxidase. This new dual chamber PCA allows more convenient and safer use of this large volume of pre-filled IV solution without worrying about drug interaction. I'd like to introduce two clinical research using dual chamber PCA. This randomized double-blind prospective study aimed to evaluate the usefulness of dual chamber PCA for IV PCA analgesia in geriatrics. All patients received dual chamber PCA just after arriving in the post-anesthesia care unit. Patients were randomly allocated to Group D, dual chamber group, or Group C, control group. In Group C, the selected continuous chamber was filled with 50 milliliters of active PCA solution and with 100 milliliters of same solution, another chamber. In Group C, the selected continuous chamber was filled with 50 milliliters of only normal saline, and the other chamber with 100 milliliters of active PCA solution. The primary outcome in this study was the amount of fentanyl consumption by PCA bolus. Secondary outcome variables are pain score, total fentanyl consumption, rescue analgesic use, patient satisfaction, recovery score, and adverse events including POA. A total 87 patients were enrolled in this study. The results are Group showed decreased fentanyl consumption in PCA bolus, decreased in rescue analgesic use, better patient satisfaction, lower incidence of POM than Group C. There was no difference in other adverse events. In this randomized double-blind prospective study, we also observed the effect of dual chamber PCA after total laparoscopic hysterectomy. In the one-channel group, only the select bolus channel was actually utilized. In the second channel group, both the select bolus channel and continuous channel were utilized by dividing two drops, tetrora ondansetron in the continuous channel, phentyne in the select bolus channel. The results are the 24-hour post-operative quality of recovery, IQR40 score, was higher in the two-channel group than in the one-channel group. The incidence of nausea at 12 hours after surgery and 36 hours after surgery was significantly higher in the one-channel group, and anti-emetic use was more frequent in the one-channel group. Patient satisfaction was higher in the second channel group. An ideal PCA should have safety, ease of use, flexibility, multi-drug use available and tolerability. Of all the PCA device released so far, the dual chamber PCA is the closest to the ideal PCA device. Dual chamber PCA can prevent mixing of the drugs. The dosing rate over time can be adjusted to some extent by filling each chamber with a different volume solution. One of the two chambers can be reserved for further drug administration. If you use it creatively in a variety of ways, it is expected to be of great help in post-operative pain management more effectively than conventional one-chamber PCA device. Thank you for your attention.
Thank you. Gives ideas. And, any questions? So the flow rate is limited to 2 ml per hour, right? This is the flow rate.
Yeah.
2 ml per hour. This is the maximum you have.
And
2 milliliter per hour.
yeah.
The maximum.
You can choose 1 or 2.
Okay.
Right? It's possible.
Okay. Quite easy and innovative idea. So thank you very much. No questions? Thank you. Great. Thank you.